Good evening, everyone. Welcome to the second session of the BMC Oncology Webinar series. As we are all aware, that today's discussion is focused on rectal cancer in young patients. I'm your host, Disha, and I'm honored to be here today. As we delve into the topic, it's important to acknowledge the increasing incidences of rectal cancer among young individuals, which poses a unique challenge and requires tailored approach to treatment and care. Before we begin, let me briefly introduce BALCO Medical Centre to all present here. BMC is a pioneering 170-bed facility in oncology care located in Naya Raipur, Chhattisgarh, India. With the state-of-the-art technology and dedicated team of experts, BMC is at the forefront of care, providing comprehensive services from diagnosis and treatment in cancer support. Today's event could not have been possible without our partners at CIPLA. And the host today is, of course, BMC. Before we begin our session, I would like to offer my gratitude to the GIDMG and the BMC, our esteemed organizing committee led by Dr. Ashok Swen, Dr. Mau Roy, Dr. Dipanjan Biswas, Dr. Gaurav Gupta, Dr. Fen Saj, Dr. Deepak Dabkara, Dr. Siddharth Tukar, Dr. Jay Rai, and we really thank you for being present here and making this possible for us. Apart from this, we have a great decorated international faculty joining us today. We're privileged to have renowned experts joining us today from Memorial Sloan Kettering Cancer Center, USA. We have Dr. Leonard Saltz and Dr. Andrea. And from the Imperial College London, we have Dr. Gina Brown here with us today. From our national faculty from India, we have Dr. Reena Engineer, Dr. Ashwin D'Souza, Dr. Aparna Dhar, Dr. Suprita Arya, and Dr. Viraj Lavingya. Let's delve into the first scientific program for today. Today's first session, we're going to have Dr. Gina Brown from the Imperial College London, UK. Dr. Brown will enlighten us on the MRI-guided therapy in rectal cancer. Dr. Gina, you have the floor.
And thank you so much for your kind invitation to speak at this webinar. I'm just going to talk about a few sort of topics that influence the treatment strategies and how imaging is playing a more important role, because many of these treatment strategies are being decided before you get the final pathology. So it is important to raise our game as radiologists. And for those of you who are not radiologists in the audience, it's about what should you be asking your radiologists, what should you be looking out for in terms of maximizing the best treatment strategies for your patients. So let me, I hope you're seeing the screen. I can't see what you're seeing, so I hope it's working. This image here shows a lymph node. To me and most trained radiologists, this is a benign lymph node. It is of no consequence. And yet, if you wander around different tumor boards, the radiologists will be saying different things, and they will very often say something along the lines of, I cannot exclude that this node is malignant. And before you know it, that patient is being offered TNT and various treatments which are completely unnecessary and won't improve that patient's outcome because they were never at risk of recurrence. And that, I suppose, is the strong message, is that very often through the process of being certain, it results in overstaging. Now, some people would say, well, it doesn't matter if you overstage a few patients because at least we're not undertreating. But what it means is that if, for example, you're looking for a readout in clinical trials and you're looking for an improvement in survival, you may lose that if you include too many patients like this. And I think that's one of the key things, that actually if this patient has not only not got a risk of local recurrence, but actually those lymph nodes are reactive and immune proficient nodes that are helping the patient, then the use of preoperative treatment in such patients is not helpful. So I'll show you the data and the evidence for that, and how indeed we can improve the certainty and accuracy that radiologists are giving when staging these tumours. So here was an example. That was a very early stage tumour. It was T2. It should be staged as T2N0, and the surgeon should not have any concern about a positive margin from a benign, well-encapsulated lymph node. So these are the sort of cases that we really need to be a bit clearer about. So here's another example of how the different utterances that a radiologist may make in a tumour board can vastly affect what would happen to that patient. So it's an 8mm lymph node. Some radiologists will say, well, it's enlarged, it's more than 5mm, therefore there's a high probability of it being malignant, and that patient will be offered chemoradiotherapy or TNT. They may look at the diffusion-weighted image and say, well, because it restricts, it's highly likely to be malignant, and then that patient also gets preoperative treatment. A third radiologist may say, I can't rule out that it's malignant, describe it, and leave the tumour board to make a decision, and then they'll say, okay, well, we better irradiate because we can't be sure. And the fourth, fifth, and sixth radiologists, who that would be those that are trained by me, would say it's benign, it makes no difference, and actually it's a good prognostic feature. This patient doesn't have any adverse features and should have primary surgery. And for young patients, this is a big deal. So to put a patient through preoperative treatment that's going to be life-changing, and for them to end up with that for the rest, the rest of their lives, the consequences of radiotherapy and indeed chemotherapy, it's too much. It's too much. So we mustn't go down the path of over-treatment. And, I've heard the argument that, well, actually it doesn't matter because some of these patients may go into complete response and that will be a win. But that's only half. And of that half, about half again would regrow with a worse tumour. So we mustn't go there. And so that's the strong message. So it's improving certainty and understanding that lymph nodes perhaps are not the routes of spread that we once thought they were. Jukes had presented his data based on the very old type of surgery done in the 1930s, and we have moved on. We have definitely moved on from there. This was the surgery, even up until the 1990s, was being performed and was informing our global trials based on this kind of resection and disease being left behind, very high recurrence rates. And of course, lymph nodes were part of the positive predictive value for pelvic recurrence. But when you do good surgery, lymph nodes no longer are a risk for pelvic recurrence. You do not see a link between enlarged nodes or involved nodes and recurrence, provided that a TME operation is being done. That is the difference, and that's why we have to take into account surgical technique and surgical abilities around the different parts of the world. So what we've also begun to understand, and I think that's largely due to some of the work our medical oncology colleagues are looking into in terms of immune therapy, is that the immune process is a helpful process. We want to augment it. We want to improve the number of the lymph nodes. We want a patient to produce enlarged lymph nodes because that is the way they are fighting the cancer. So in fact, we want to enhance this and not shrivel it and attack it. So in the future, I suspect we are going to get a better understanding of the different pathways of spread and also the immune mechanisms that prevent those pathways of spread. There is a pathway of spread that has been really hugely neglected, and possibly because most pathologists have relied very much on measuring and looking at lymph nodes, and they have rather neglected this phenomenon of EMVI. So tumour spread into veins is a really important feature that we need to look out for, and we can see very well on imaging because we can see the signal void, the lack of flow in a vessel, which tells us it's a vein, and then we can see that's been expanded and disrupted by tumour signal. So that's the thing that we can see, and it's present in 30 to 40% of the patients that we scan. And when we see it, it is such a bad prognostic feature. It is much worse than lymph nodes. And it's also linked very strongly to the development of distant metastases. What's very interesting about this is reversing that status in the pelvis through radiotherapy eliminates the rates of metastatic disease that we see. It halves those rates. So there is something about controlling the disease in the pelvis as a first line of attack that seems to help these patients survive their disease. So that's an example of what we should be reporting. So no, we don't report that as a malignant lymph node because it's tracking a vessel. It is a tumor deposit. It is an extranodal tumor deposit. And therefore, the answer to this is number 3. It is also a focus of EMVI, but it's discontinuous. So when we look for these on the scans, we're looking for a distinct appearance, which is causing expansion of the vessels and following and tracking the vessels. That's the distinguishing feature. And previously, we all called them lymph nodes, and they're not the same. So if we can separate out this from a lymph node and identify these in patients, which we can on high resolution scans, we are prognostically separating out those, in inverted commas, stage 3 patients that actually matter. And we all know that about half the patients with lymph node positive disease never get anything, but the half that have this, tumor deposits, they're the ones that we need to be on the lookout for, and we need to maximize and intensify treatment for such patients, not just their treatment, but also their surveillance because of their risk of disease. And this, I think, is also very interesting that, in fact, when you look at the clonal origins of metastases and compare them to their origins, were they in the lymph nodes, were they in the primary tumor, it seems that for the majority of tumors, the tumor is bypassing the lymphatic system altogether in order to reach their destination. And how would they bypass the lymphatic system? They do so via the vascular system. And that, I think, is proof in a way that we have placed too much emphasis on lymph nodes and really ignored an important pathway, a killer pathway of spread, which is the vascular pathways. And so I think in the future, our strategies need to really rethink how we develop our protocols. You stop asking radiologists what they think of the lymph nodes, and you start asking the radiologists, have you looked at the veins? Have you seen if there are tumor deposits along the veins? Have you performed a high resolution scan in order to be able to visualize that? Is it a T2 weighted scan? You are not going to see this kind of disease on low resolution diffusion weighted or other sequences. This has got to be a high resolution T2 sequence. And what you then find out is that the node positive tumors have exactly the same prognosis as T1 and T2 tumors that are N0 if they don't have EMVI or tumor deposits. And the reason for that is purely because of this pathway of spread. And it also is that the lymph nodes are stopping the tumor spreading. So in the patients with and without EMVI, we get this big difference in survival. So that means that we can have a strategy that uses this information to really decide who should get preoperative treatment. And I'll make, because we've got only 15 minutes, I'll make this my last slide, if that's okay, perhaps. And Disha, to summarize, we should be able to stratify patients into those who can undergo primary surgery, because we do not need to get to a situation where every single patient is receiving preoperative treatment. It would overwhelm our health systems. Who are the ones that we can avoid preoperative treatment to? The ones where the tumor spread is less than 5 millimeters, the TME plane is clear of disease, they are EMVI and tumor deposit negative. And the lymph nodes in that situation, we have now proven and published on, does not matter. It doesn't change the outcome. In fact, it may benefit the patients to have those lymph nodes present, even if a few tumor cells are within them. So those patients benefit from primary TME surgery. And for a young patient, the benefit is even greater. For the tumors that have more than 5 millimeters of spread, tumor deposits or EMVI positive disease, whether or not the CRM is safe or unsafe, preoperative strategy is important. Chemoradiotherapy is the important component of that we've observed in terms of reversing EMVI and tumor depth of spread. But the chemotherapy is also important because of its systemic effects. And for the lower rectal cancers, where the TME plane is involved, where tumor has spread into that intersphincteric space, they also benefit from a preoperative strategy because you're lowering the risk of a positive CRM. So these are the groups of patients who should be offered preoperative treatment, and we should start to allow the patients with the earlier prognosis, good prognosis tumors to escape over-treatment. So thank you very much.
Thank you so much, Gina. I think we are guilty of over-treating our patients, and you did a great. I mean, I remember you trained about 20 of our radiologists when I was at Apollo, and you personally attended the MDTs and held our hand through as well. But how do we replicate that all over? I mean, is there an AI modeling being done so that we have a virtual Gina everywhere?
I think people are certainly thinking about that, but actually, I think that's not going to be the solution because things change, surgical techniques change. The biology of the disease is modified by the treatments. It's individualized. There are so many other factors that have to be taken into account. I think you can put imaging findings into an algorithm to optimize treatment decisions. That is where AI can work. You can help radiologists by giving them, examples of what is an important lymph node, what is not, what is a tumor deposit, what is EMVI. And I think also asking the radiologist the right questions, asking them, have they looked for EMVI? Have they looked for tumor deposits? You'll then, if you've asked them that question, they'll probably make an attempt to search for those things. And, talking about CRM in terms of enlarged nodes is a non sequitur. It doesn't work. So I think it's more to do with a culture change in terms of what's being required. And managing radiologists' kind of standards is about, setting guidelines, following them, having training programs, and making sure that those are updated, that people move along. What I was teaching radiologists 10, 15 years ago is not what we're teaching them now. So we move along. And that's why AI won't necessarily work, because we're always thinking about, well, why did that patient recur? What can we have done differently? And what is the next step in terms of preventing those things? So, yeah.
Thank you. And just to tell everyone, I worked with Gina at the Marsden, and she ran the GI MDTs and could tell David what to do, which I think very few of us could tell David Cunningham.
Could I ask a question? If
Yes,
that's okay?
Yeah. Please.
So amazing lecture, and just to let you know, I try to invite Gina every year to Dubai, and every year she says no. So hopefully, maybe this year we can convince her to come. But I have a question. I think this algorithm makes a lot of sense. But now we've all gotten on board the prospect bandwagon. As you remember, the data came out last year at ASCO. Do you think that needs to be further refined based on MRI findings, like the EMV being positive or not, in these patients, where we can potentially exclude radiation therapy or not based on EMV?
Yeah, I would be really, really scared about avoiding radiotherapy in EMVI positive patients. The reason being the pathway of spread in the pelvis is so nasty. It's so infiltrative that you need something fairly explosive in the form of radiotherapy to deal with that, to permanently deal with it. I think we think about in a very simplistic, and I apologize to Len and Andrea. I have a very simplistic view. I think chemo is fantastic at mopping up, as it were, but it's not a primary explosive, destructive thing on the pelvis, which of course is massively over treatment for patients who don't have those features. So definitely there's a role for avoiding radiotherapy, but I wouldn't start with the EMVI positive patients as the first group. I think we can certainly avoid radiotherapy in that second group that I put on the slide, the T3AB lymph node positive, a CRM clear. But they're a big group. That's half the patients. So if we can avoid radiotherapy in those, then we can decide, well, what is the impact of chemo in those?
Hi, Gina.
Oh, Reena, go ahead.
Hi. So now in the era of organ preservation, now this algorithm will change at least for the low-lying tumors, because even if they're T2N0s or T3 early T3, but they're lying in the last 6 centimeter, then definitely we would go ahead with chemoradiation if they don't have those other features which would exclude, which will not be appropriate for organ preservation. So yes, this algorithm is changing. And how is the trigger trial going on? I want to know.
Well, yeah, I mean, I think that's I didn't have a chance to talk about trigger, but yeah, I think that's going to be quite key, because one of the things here is the possibility that a tumor that is not necessarily in complete response at that moment in time, but has had a good radiological regression grade, but clinically seems like there's a residual tumor. That's experimental, and we do need a trial to say, okay, let's ignore the clinical findings and just say, well, this is a good TRG response, let's watch and wait. I don't think people should be doing that outside of a trial, and I don't think people are doing it outside of a trial. So I think the trigger trial will be important. I do think that saying anything below 6 centimeters as being potentially needing an APE isn't right either. So for some patients, if it is possible to join them up and they've got a good prognosis tumor and the TME plane is safe, just because it's at 6 centimeters or 5.5 centimeters does not necessarily preclude primary surgery. So I think it definitely has to be individualized, because the thing is that the watch and wait isn't guaranteed in these low-lying early tumors. And that's the thing we have to remember, that if you've got a tumor at 5 to 6 centimeters, not touching the sphincters, with a clear centimeter of clearance, a TME operation will result in sphincter preservation, guaranteed, pretty much. Whereas if you're in that half that hasn't responded, you're in a worse situation, because then you have to have an APE, because joining up someone's irradiated sphincters is never going to be a good idea. So I think it's a nuanced conversation, and I think for young patients, it's a really important thing to say to them that, we have an opportunity to join you up, we have an opportunity to give you radiotherapy, but you have a half a chance of not succeeding with that, and then a half chance after that of it regrowing. So this isn't as straightforward, and individuals will want to take different paths of risk. And I don't know what I would say if somebody said that. It's a difficult decision, but I think you have to present it in that way.
Great.
And what I meant was after opera trial, and even what we see in T2 and early T3 tumors, the 80% do respond even in our center. So we are very much encouraged, and we offer them upfront surgery versus chemoradiation with chance.
Exactly.
So we have an MDT discussion, and we always give them a chance of the well-selected cases, not all.
Yes,
but
exactly.
We do give them a chance, and then it's left to the patients. Yeah.
Exactly.
Thank you, Reena. Thank you so much, Gina. There's a question: what resources are available for general radiologists to learn about rectal cancer staging? So, I can say on your behalf, you have a website, and I have downloaded the synoptic reporting templates and everything from there. Is that still there?
And we do online courses, and lots of radiologists from around the world have attended them, and I'm sure something can be organized in India if need be. It's not a problem.
Yeah, great. And I hope we see you in Dubai this year.
Okay, Gina, have to give you a bit more advance warning.
Gina, if I could ask you one question. You mentioned as you're talking about where there are overcalls in DMT discussions, they've restricted diffusion. And I've often been discussing in our DMTs that, like every other tool, it's imperfect. How do we help understand the false positives with restricted diffusion? Where do we? How do we use it properly?
I don't use it. I have focused all of the research, the training, the trials, and all the data that you see has been based on high-res T2 because it works. I remain to be convinced of any added value of the diffusion. I think I call it the confusion-weighted technique because I think it changes people's minds.
I'm going to start using that term. I like that because that's often the discussion I'm having with our radiologists is let's not get carried away by that one factor.
And Gina, you would say this for regrowth as well?
I really think that certainly in identifying patients suitable for watch and wait, I rely entirely on high-res T2. If a patient's got regrowth, almost always, irrespective of the diffusion, it's the clinical assessment that picks it up first. Pretty much on the luminal side. On the extraluminal side, it'll be the high-res T2. Yeah. So I'm very much in favor of sticking to things that really work and that, in our experience, work and that don't cause confusion. And unfortunately, in my mind, diffusion-weighted imaging contributes to low-level confusion and over-investigation and just general panic. And if we removed it from our protocols, nobody would miss it. It's just one of those things, nobody would miss it. But if instead we focused on high-res and actually spent time looking at those high-res instead of being distracted by this other stuff, we would actually win a few more cases. I think
you made a really important point about the physical exam being the driving factor, especially in the regrowth question. Just taking a look at our experience here, based on sort of the subjective sense that MRI for that question is not the right tool. Correct. And I suspect that our intense use of MRI and surveillance is going to turn out not to have been the right answer.
Yeah, I think you're right. I think that given that most of the regrowths are intraluminal, you're right. But in those cases where there has been EMVI at the outset, often we find that EMVI is the last thing to regress and the first thing to regrow. So sometimes it is worth doing it, but bearing in mind that the luminal side will definitely be seen by the endoscopist first, because they'll see that sort of bleeding, the change. And we won't necessarily, it's too subtle for us to see on any kind of imaging. It's not a thing to image.
Yeah.
So, but the extraluminal regrowth, that's where we come into play, because just a couple of millimeters change in the size of a treated nodule, an EMVI focus, that can alert us to the possibility of regrowth. So I think they're complementary. And I think you're right. Where there hasn't been any extraluminal disease in the first place, you probably don't need extraluminal monitoring.
We probably don't need monitoring, and we have to learn what not to look for, because I think worrying about various areas of thickness and worrying about nodes is probably off target. We're seeing that we're being pulled into false positive surgeries that in retrospect we didn't need.
Yeah, exactly.
Great. I think that's wonderful discussion, Gina. Thank you so much.
Thank you.
It's fantastic. So we move on to our second talk of the evening. Dr. Andrea Cercek. She's the section head of the colorectal cancer at Memorial Sloan Kettering Center in New York. Looking forward, Andrea, to listen to your talk on state-of-the-art treatment. I know the time is really short.
Okay, perfect. So yeah, I will maybe jump through a few slides, but it's my pleasure to be here today. I'm going to start with the case, which is a little bit shocking and extreme, but I think unfortunately we're all seeing younger and younger patients with rectal cancer. So this was a 15-year-old boy who had some change in bowel habits, told his mom, they went to the doctor, they said, oh, it's probably nut allergies. And then several months passed from when she changed his diet, and it was during COVID and they were home all together, and they noticed that he was just in the bathroom all the time. He didn't say anything, didn't complain. And then turns out he was not evacuating, bleeding, etc., and was found to have a rectal tumor, mismatch repair proficient. Thankfully, no metastases. So he was referred initially to pediatrics, and then they called and said, you have the Young Onset Center, please help. We don't really deal that much with colorectal cancer. So it was this nice, actually, joint treatment. genetics were completely negative, and his parents ran to get colonoscopies. They were 42 and 43 at the time, and neither one of them had a single polyp. So seemingly completely sporadic, which is obviously what we're seeing worldwide and why it's so important for all of us to be talking about how to really optimize treatment for rectal cancer in young patients. So as you know, Gina has really nicely talked about the beautiful staging, and particularly when you have an expert doing it, I think it's much easier than outside of academic centers, I think. But one of the initial things that we did, and this was now years ago, and we've adopted certainly, is moving treatment into the total neoadjuvant setting, because with the combination of radiation and surgery, we do see a lot of morbidity, infertility, bowel and bladder dysfunction, sexual dysfunction, and then just about a third of our patients do require permanent colostomy because of the tumor location. And this is always important, but it's increasingly more important, obviously, with this 15-year-old, but even in our 20, 30, and 40-year-olds. So we've moved treatment in the US now to total neoadjuvant therapy with chemotherapy and radiation up front, where we theoretically treat early micrometastatic disease, as Gina said, sort of mopping it up, but we know that mopping it up early does make a difference. We believe it makes a difference. We know this improves responses. And then importantly, for some of our work, actually, it enables selection of non-responders. And then critical, I think, for young patients is this opportunity to individualize therapy. Thinking about non-operative management, thinking about omission for radiation, particularly in young women of childbearing age, and then biomarker selected therapy to improve neoadjuvant therapy. So TNT, we know, is associated with higher path-CR and clinical complete response rates. We looked at this a few years ago, and it's obvious. We're giving everything up front preoperatively. Responses will be improved. And it also enables omission of surgery. Now, there are potential patients that don't require all of this therapy, but certainly in someone who has a very low tumor that would require an APR, on the sphincter, very close to the sphincter, that would require an APR, or even a coloanal anastomosis. I think this is a really important conversation to have, because especially when they're so young, an entire lifetime ahead of them, it does affect quality of life quite significantly, obviously with an APR, incredibly disfiguring, but also with the coloanal anastomosis, where sometimes patients then choose to have an APR because they can't manage. And so I'll just show, so everyone's well aware of the Oprah data, which really asks the question of giving everything up front. What are the rates of non-operative management? It was randomized to either chemoradiation followed by chemo, or chemotherapy followed by chemoradiation. It was not powered to answer this question, but that was a randomization in the study with the goal of watch and wait non-operative management. And what we learned is that there are significant organ preservation rates with giving total neoadjuvant therapy upfront in both arms. The chemoradiation followed by chemotherapy arm did perform better in terms of local regrowths. However, I would add the caveat that there was a lead time bias in the group that received radiation second, where they were declared a near CR or CR, and the follow-up was not as long. And we know that the longer you wait from radiation, the higher the response is. And so that group was slightly unfairly placed in the bucket of potential CRs, and then had these dropouts. And I say this with the caveat because it has been accepted at many centers to, if you're thinking about non-operative management or even for rectal cancer in general, to do radiation up front. But I would disagree with that. I would, obviously, as Gina discussed, staging is critically important. It's not for everybody. Certainly, I'm a big believer radiation up front is not for everyone. If there's a patient that will undoubtedly require an APR unless they have a complete clinical response, and that you'll want to radiate, to just give it your best. If there's concerning features on MRI and you want to radiate to sterilize the pelvis better, then that's something that we should do. But otherwise, as a general group, it's really not a one size fits all. Everybody needs to start with radiation, in my opinion. Oops, apologize, jumping ahead. So then the next study, which I think brings up a really important question for our young patients, is the PRODIGE study. So PRODIGE, led by the French group, looked at effectively the kitchen sink upfront. So FOLFIRINOX for 3 months versus standard chemoradiation followed by TME. But in this study, they had FOLFIRINOX for 6 months, and then everyone received radiation therapy. The results were positive. I'll show the data in a second. The pathologic response rates were higher. There's actually a benefit in terms of metastatic rates, but everyone received radiation as well. I would have loved to have seen what happened here just after 3 months of FOLFIRINOX alone, whether or not everyone indeed need radiation in that group, or did they have a complete response or not. This is a lot of chemotherapy. There is a lot of toxicity associated with this chemotherapy. Most patients do tolerate it well up front, but it is something to consider, when we're treating our young patients, because unfortunately what we don't know from this study is, would FOLFOX up front have been just as good enough as FOLFIRINOX, and who are the patients that really need this, combination therapy. I've personally used it in patients with very advanced locally invasive T4B tumors, where we really try to give it our all in order to preserve as much of the bladder. For example, sometimes they're bladder invasive, et cetera. So again, just most important is to consider this. But even with this study, there's now many centers in the US that are just everyone, sort of on protocol, receives FOLFIRINOX up front, and then everyone receives radiation. And I certainly, could not agree more that is over treatment. Some patients do need it, but for many that's over treatment. And there's the data, and I know everyone's familiar with it. So in the interest of time, I will just move ahead. So another very important consideration is in our young patients is, do we need to radiate everyone's pelvis? Location matters. We have a lot of experience with the very high tumors straddling the peritoneal reflection that they don't need radiation. We don't routinely do it. I believe that response to systemic chemotherapy matters. And then, of course, with our trial, biomarker-driven therapy also can make a difference, and we can omit radiation in certain patients. And so we know radiation benefits the pelvis. It doesn't affect affect metastatic rates, and that is what our patients do succumb to. So not a one-size-fits-all here, and everyone's very familiar with the PROSPECT study, which Gina alluded to as well. So here the question was, could we selectively omit radiation from patients with higher rectal tumors? They received just 3 months of FOLFOX up front, and then were restaged. And if they had a greater than 20% response, they went on to surgery. If not, then they jumped onto radiation. And no differences in overall outcomes. But what I do want to spend just a moment on is that in this group, so this was a study that opened in 2012, so many years ago. We didn't have all the, sort of sophisticated MRI staging here. The pathologic complete response rate of just 3 months of FOLFOX was 22%. So 1 in 5 of those patients didn't need anything more than just 3 months of chemotherapy. We have very good tolerance of 3 months of chemotherapy. It is a rare patient that even has some residual neuropathy. And so, it's a significant percent of patients here. And we have no reason to think that biologically a tumor at 10 centimeters would behave any differently than a tumor down by the sphincter at 1 centimeter. And so there is this patient population that is very sensitive to chemotherapy. The question is, who are they? So I think that's a really important question that we really need to focus on, because if we know that, then those patients get just, a few months of chemotherapy and potentially no other intervention. So really an important thing for us to keep in mind. And then what I find, most exciting personally is biomarker driven therapy that can really augment neoadjuvant responses. So Gina talked about this a bit as well. Locally advanced mismatch repair deficient cancer, DMMR tumors are one of these biomarkers. They're about 5 to 10% of all of our early stage rectal cancers. We know they're less sensitive to chemotherapy. And the way that we actually conceived this study was that we noticed in our patients where we were giving total neoadjuvant therapy and we're giving FOLFOX up front, a proportion of patients either just progressed right through it or had really rapid recurrence. And that was really strikingly different from our MSS patients. So when we looked back, these patients were mismatch repair deficient, and 29% actually, the 21 patients that we looked at had progression of disease to chemotherapy. This has now been shown in Foxtrot. It's been shown in other studies as well. And at that time, though, we said, okay, the patients had regrowth, gave them PD-1 blockade, and they had these beautiful responses. And obviously, we knew about these responses in the metastatic setting. So the idea of the study with dostarlimab was to give dostarlimab upfront, effectively as total neoadjuvant therapy, replace our initial treatment with FOLFOX with dostarlimab. And we designed the study in such a way that could we get away with replacing chemotherapy and radiation, or really replacing all modalities of standard treatment with just PD-1 blockade. So this was the trial. We've since expanded it. So the patients were monitored really closely. They had dostarlimab for 6 months and then a full evaluation with MRI, with an endoscopic exam, and also a PET-CT. That was just a research question for us. If there was no tumor, they were followed by non-operative management, which we had well-defined, slightly more conservative than we used in OPRA. If there was still residual disease, they were to undergo chemoradiation and then again could be followed non-operatively. So initially we had a Simon's two-stage design, and then we had very positive results in the initial 14 patients. So we expanded the trial. So I will just briefly show you. So this data is actually actively being updated, but this was 36 patients. We're now up to the high 40s enrolled on the study. Age quite young. We have a bit of a range, 26 to 78. The patients by MRI staging do have big bulky tumors. As Gina mentioned, a lot of these nodes may not be involved with cancer, but it is our best staging. So 94% of them are indeed node positive on MRI staging. And then I will just briefly, actually, I'll show the data after in terms of Lynch patients. So this was our second patient on the trial. She had several months of symptoms, just like the 15-year-old boy. Didn't really think much of it, and then developed bad back pain. Was found to be anemic, and then had this endoscopy. So big near obstructing tumor, visible on MRI as well as PET-CT. And what we noticed, as I mentioned, we follow the patients really closely. So we did an endoscopy at 6 weeks. Clinically, their symptoms improved drastically, very, very quickly, which we weren't expecting at first, but this has been seen now over and over. And they had beautiful response to just 2 cycles of treatment. The bleeding's actually from the biopsy. She was no longer bleeding, no longer in pain. And then by 3 months, she had a clinical complete response and a near complete response on the MRI. So we do see this lag in the MRI response, which is seen also in MSS patients, but it's something important to talk about as this treatment is now done worldwide. Many places have approval for PD-1 blockade in neoadjuvant rectal cancer patients. I get a lot of emails. I find most people are restaging with MRIs, and I keep having to say, you really need to do an endoscopy. And that was Gina's, and Len's really important point. Endoscopy, especially for follow-up, but even for response, is really important in rectal cancer. And so by 6 months, she achieved a clinical complete response, has been disease-free. She actually had a baby this past October and is doing fantastically well. So had absolutely no sequelae from treatment. And I just saw her for her 4-year follow-up. So she's doing great. So this was our data that I presented a little under a year ago. No, still 100% responses. No one needed chemotherapy, radiation, or surgery, and no local regrowths and no distant disease. So this, the beauty of immunotherapy really is, especially when we give it early on. I think it's obviously a combination of sensitivity, but then this vaccination phenomenon, it seems, is also critically important. So we're going to present the updated data hopefully this June at ASCO. And then just a really important note, the majority of these patients do have Lynch syndrome. It's about 69-70%. in our series and also in other series. So super important if there's a mismatch repair deficient tumor to do germline testing on the patients. And then just a really important note, these are young patients. We have to consider longevity. We have to consider treatment into, life in survivorship. There is potential toxicity of treatment, including overtreatment, sexual health and fertility, psychological impact, as well as financial toxicity. So to address this, we opened a center. It's actually been 6 years next month to focus on our young patients. One was a research focus, but equally as important was to sort of introduce all of the support services upfront to really help them navigate diagnosis, treatment, and then into survivorship. Unfortunately, we have no shortage of patients. This is all colorectal cancer patients, but we're about 600 a year. So over 3,000 patients now enrolled. Super important question. I alluded to this. Gina mentioned this as well. I think we all, feel strongly about this. Do we really need to give everyone aggressive therapy? Does everyone need Prodige if they're 23? I don't think so, but yet we do it. Certainly, this is data from the metastatic setting. We looked at this in our patients. This was metastatic disease, but just asking the question, is this the same biology? And yes, we didn't see any differences in responses. So just an important thing to keep in mind when we treat our patients. There's a significant chance of toxicity from our chemotherapy. Obviously, I mentioned radiation and surgery, but chemotherapy is not always, walk in the park. 3 months, typically, we don't see any problems. But if we're thinking about more combination chemotherapy, there could be issues. Fertility is a huge problem. We do ovarian transposition. We've even done uterine transposition at MSK. She's now pregnant. There's been 2 pregnancies with the uterine transposition in Brazil, which is just amazing. But we're looking into this prospectively to see how we could best advise our patients, even from chemotherapy toxicity. And then an important sort of cohesive center where we introduce interventions early on, particularly social work. Many of our patients find that really helpful. Most of the question, like 80%, ask, how do I talk to my young kids? So back to our patient. So 15-year-old sitting in front of us, we had to really think about his life, the cure, obviously, but what's going to happen afterwards. We decided to do total neoadjuvant therapy. His tumor was on the lower side, actually quite low. So he had 4 months of Kpox, then he had chemoradiation. We were able to use protons. He had a fantastic, complete clinical response. He's done incredibly well. He's now in college. It was a tough discussion, though, at DMT. It was not easy because we didn't follow standard, which would have been surgery. His mom was fully on board. He was okay with not doing surgery. He obviously didn't want it. And so we've just been watching him closely, and he's been doing really well. So I think we need to really think about individualizing therapy. We have a lot more work to do to figure out which treatment is best. How do we stage patients? Which therapy do we turn to first? And then also focus on supportive measures for these patients to help them in survivorship. Thank you for your attention.
Thank you, Andrea. That was brilliant. Any questions? I have one. Do we know why? Because in India also, we are seeing so many young patients, and colorectal cancer is on the rise. And we don't have a clue why. Do you?
Yeah, I would say totally honestly, we don't either. There's a lot of reports about, certain sort of sedentary lifestyles or obesity or risk factors, but they're really anecdotal, small case reports. When you really look at the patients across the world, they don't fall into those typical risk factors. The tumors are left-sided, not right-sided. And, certainly this 15-year-old with a seemingly sporadic tumor, there's really no risk factors that you could even consider in someone like him. So I think it's environmental. It's definitely multifactorial, probably. We're chasing antibiotics, microbiome, microplastics. I think it's something that we're all exposed to, though. And the question is, could we just identify the people that are at risk? Because what's interesting, and I didn't show this data, is in the United States, in the most recent colorectal cancer statistics, so in 2023, there is this actual uptick now in the 50 to 64-year-old group in rectal cancer. So the shift is actually towards more rectal cancer, in all ages. And now we're starting to see this rise. So it's the people that were born in 1950 and later that are now getting older that are also at risk. So it's not really an early onset. It's just this sort of change, probably due to exposures, most likely that started around, people were born in 1950. That's when we see the uptick. So like 1960, 1970, first in the UK, the US, higher socioeconomic countries, and now everywhere else as well. So, but probably multifactorial.
Can I ask a question,
Yeah,
Bhawna?
please, I can see a lot of questions. Go ahead.
Amazing overview. Thank you so much. Amazing work that you're doing as well. But I have two questions. I come from the United Arab Emirates, and we see also a lot of young patients with cancer, not only colorectal, but across the board. The median age of diagnosis of anyone in the UAE with any type of cancer is like 40. So we have very, very young patients over here. My last colorectal cancer patient was 29 years old, so with 12 lymph nodes that were positive. So again, we've got very young patients. And the dilemma that we face in our MDTs is that here we're trying to de-escalate modalities of therapy for our rectal cancer patients. We have this option of watch and wait, but can we really apply it to these really young patients? Do we have the courage to actually say no radiation therapy if they fit prospect, or just give immunotherapy if they've got MSI high disease and and leave them alone? Because if your 15-year-old had MSI high disease, would you have not given radiation therapy to him? Is my question. So
100%.
really difficult in the end.
100%. I mean, yes. I think really what's happening is it's almost like we're aging kind of prematurely, and these changes that occurred, if they're sporadic, right? So MSI is a different story if they're Lynch, of course. But to answer sort of your first part of the question, I think the biology is the same. I didn't show this data, but we looked at in metastatic patients, the tumor genomic signature, right? So we looked at, RAS, BRAF, et cetera. When you look at it side by side, so rectum versus rectum in the, let's say, 30-year-old versus the 80-year-old, there are no differences in terms of the genetic makeup. So this presumed pathway of adenoma to carcinoma and all the changes that occur is the same. Maybe it's accelerated, maybe it's not, we don't know. But once the tumor forms, the response to chemotherapy, the genetic makeup is the same. And so for us, you saw with this 15-year-old, it was a, sort of tough decision. We definitely discussed it at the DMT, but we certainly felt that once he achieved a clinical complete response and the tumor was gone, why would it be any different than a tumor that's gone in a 70-year-old? We can't see it on MRI, we can't see it on endoscopy, it's gone. So let's watch it, and to answer your question, the MSI, 100%. We have not seen anyone, not a soul has needed radiation or surgery or chemotherapy. So, definitely in MSI, immunotherapy upfront makes the most sense. And it's beyond just, the local treatment. I think there is this vaccination that happens as well, and hopefully, prevents recurrence and distant disease.
So my
Shahina,
second
if I could-
question.
Shahina,
Yeah, go
before we
ahead.
get to your second, if I could just elaborate further, I want to turn it around the other way. I think it's actually one of the things we have to be very careful not to do, to let our emotions about young patients interfere with our judgment. Because think about it, you get somebody that has clinical evidence of a complete response, but you say, oh, but he or she is young, therefore we better operate. You operate, it's a path CR. Now that person's going to live another 60, 70 years maybe without a rectum, with all the, okay, so there's no free lunch. Okay, there's risk in whatever we do, but using the person's age as a reason to say, let's be somehow more aggressive as if we know that's better, I think is the trap we have to avoid.
Absolutely. So my second question is about MRD testing in your 15-year-old, because I know Leonard loves MRD testing from our previous discussions. Would you do MRD testing in a patient that you're watching and waiting with just chemoradiation and chemotherapy? He's got a complete response. He's 15 years old. He's going to college now. Would you do MRD testing in him as you're watching?
Yeah, cover your ears. No, I'm just kidding. So it's a tricky question, right? I didn't for him, but this was a few years ago. More and more now, our patients definitely in New York, we do it, and it's because they come like, okay, I want this and I want that done. The issue, obviously, which is what you're asking about, is what do we do? You know, for rectal, we don't, but for colon, we do now have a trial, several trials actually, treating MRD, you know, and it's either observation or it's FOLFIRI. And so on a clinical trial, you know, I do it. It obviously adds a ton of time to our clinic discussions, you know, a lot of anxiety for some people. I think we'll learn more as our assays get better too. I think it'll be much more informative. You know, unfortunately, the stage 2 study, the COBRA study was closed because the too many false positives. And so there are certain issues, but I think, you know, for me, it's a little bit of a mix, a little bit depending on the patient, or if I have a research question. Like on all of our studies, on the MSI study, and we have another HER2 neoadjuvant. We are doing MRD testing, so we'll see what we learn.
And my last question, I promise, because Bhawna will kill me otherwise, is that
China, can somebody mute themselves? There's a lot of noise coming from somewhere. Oh, you go ahead.
Okay, last question. I saw interesting data at ASCO GI and and some of the other symposia and publications that have looked at adding immunotherapy, dual immunotherapy in patients with MSS disease. So what are your thoughts there in terms of bringing it into the early stage setting in combination with chemotherapy? Again, just a hypothetical question of where we're headed with immunotherapy in the MSS space.
Yeah, I mean, I think we are headed there. That's actually a trial that will have opening soon as well. So, you know, I think that we've seen this before with dual agents, with CTLA-4 and PD-1, that early stage tumors respond, and it's about 20 to 30%. So there definitely is this, you know, potential combination. And I guess the problem is we look at immunoscore. We don't know really what to look at. We don't know who those patients are, but that do benefit. So that's something that we want to study, and I think we are headed there. The issue, of course, is, you know, in rectal cancer, in certain patients, we do kind of, when we want to maximize neoadjuvant therapy to not necessarily operate, certainly if they need an APR, for example, it makes sense. The problem is, of course, the toxicity. And if it's unnecessary toxicity, which is not trivial with CTLA-4, in patients like in colon cancer, where they can be cured just with surgery alone, you know, so back to the point of overtreatment. But I think I think it is definitely something that should be studied, and then that we'll study as well. But I wouldn't do it off trial.
Great, thank you. Reena and then Gina. Reena, you go ahead first.
Just one question. Our age of presentation is very young, like 40 to 45-year-old median age. And majority of our patients, the young colorectals are like 18% of them are signet-ring, mucinous, poorly differentiated cancers, and they do not respond to chemoradiation, the routine chemoradiation as well. So you have any comments and you have any suggestions, or have you observed anything like this?
Yeah, do you do mismatch repair testing, or
yes,
they
we do, and then only 1 to 2% are positive. So, like,
yeah, that's surprising, because I would have bet, if you asked me, I would have bet that they're Lynch and they're MSI.
We've done this, and it's very, very occasionally. Hardly we see one patient a year who will be MMR.
Do you and the response is endoscopic or just by MRI? Because mucin, you know, sometimes you can't tell on MRI.
MRI also, we have all DRE, MRI, and they don't respond so well, you know, like they never go for, hardly they ever go for organ preservation. So their outcomes are also inferior.
And do you do chemotherapy then as well, or
yes,
do you do?
Yes, we have started doing TNT for all. So still, you know, like.
Yeah, no, that's, I don't really have a good explanation. We've seen it. We've definitely seen it in our mismatch repair deficient patients, and then the mucin on MRI can be very challenging. But this lack of response is kind of odd for us. Usually with the combination of chemoradiation and chemotherapy, we do see at least stability or some response. So that's anything odd on genomics. Have you been able to do NGS?
Signet-ring is a major problem in our.
Yeah. Have you done next generation sequencing on the tumors?
Yes, we have done, but they are not, you know, they are not positive.
Nothing interesting.
No.
Yeah.
So we're discussing a case, Reena, and I think we should do NGS in these patients. I mean, I'll actually allow as many questions because most of the questions I was going to ask in the case are being talked now. And it's a brilliant that you all are here. So, Gina, did you have a comment? No. Okay, so I'll just ask you, what are the pointers from Dr. Fensaj, he's our medical oncologist, that you look at when you have to choose between FOLFIRINOX, CAPOX as neoadjuvant chemotherapy?
I would say for me, 9 times out of 10, I choose CAPOX, maybe even more than that. For the FOLFIRINOX I've used in just very locally advanced invasive tumors, T4B, really, bladder, uterus, vaginal wall, where I just know that the morbidity of surgery is incredibly high, and I want to just maximize that response. And
could I point out that FOLFIRINOX is the question in the Janus trial, which is actively accruing. So we're running a national clinical trial pretty much to ask that question. Yes, it's post-radiation, but I think it's the same question. And I think it's important to remember that we have 4 negative trials of irinotecan in the adjuvant setting in colorectal cancer. So the expectation that this is going to do the things we want it to do is far from established. It's a good research question because we really do have equipoise on the topic. But I'm always cautioning against embracing our research arm of an ongoing study before we know the answer. There's reams of evidence that doesn't pan out often the way we want.
And one question that I'm asked often is the bolus 5FU question. I mean, in curative settings, I know in modified FOLFIRINOX and palliative setting, we no longer give bolus 5FU as part of FOLFOX. But do you give bolus 5FU in neoadjuvant and adjuvant settings in all your patients?
We do.
You do, yeah.
We do.
And Viraj, you had a question. Does immunotherapy use in Lynch-related colorectal also protect them from getting another malignancy?
That's a great question. So we actually looked at this, and Emily Harold is the first author. Sophia Stadler's the last author. Nature Medicine came out in October, and it's interesting actually. What seems to happen is that they have less visceral tumors, so lower rates of colon, etc., but higher rates of skin-related Lynch tumors, which are obviously much easier to manage. And why that is, we don't know, but we're thinking about, Dr. Sadler's thinking about a sort of prospective study to evaluate whether this seemingly protective effect.
And Suprita, you have a question. SAR and ESGAR guidelines. These must be the radiology guidelines. Include for you, Gina. Suprita, do you want to say what you're saying? It's quite long. Okay, we can't hear your voice, so I will say. So include diffusion-weighted imaging as essential in addition to T2W, high-res images.
Yeah, but sadly, the evidence is lacking for this word essential, other than people sitting around the table nodding and agreeing with each other. I have a concern about the term consensus guidelines when those guidelines don't produce evidence to back up any of those statements. So there's no published evidence for the added value of diffusion-weighted imaging in the particular questions being asked. And that is the problem. And that's why I haven't, if there'd been evidence, if there had been something really persuasive to say it's actually going to add some accuracy, I would have taken it up with both hands. I would have absolutely be promoting it. And I don't promote it for a reason, because I cannot find the evidence. And I'm sorry, I just think that those kind of consensus guidelines, they need to be policed a little bit better than mates sitting around a table, sort of patting each other on the back at their own research papers and saying that, yeah, weren't we wonderful? So I'm really sorry about that. I just think we definitely need some persuasive prospective studies with outcome data to say something is giving you prognostic value.
Great. Thank you, Gina. I think we'll move on to a last talk and then maybe discuss one case quickly. It's a pleasure to invite Dr. Leonard Saltz. I have been working with him on our molecular MDTs, and it's such a pleasure to have somebody from a high-income country who chooses wisely. And he's the chief of GI oncology at MSKCC. Thank you, Dr. Saltz. Please go ahead.
Title was a little out of date. I've not been the chief of the service for some time now, but still happily a member of it, and happy to talk to you today. What I'm going to do, Shahina, I made these slides last night, so don't take it personally when I get to the end. I'm going to give a little bit of a sort of a grumpy old man talk and say what not to do, because I think we do kick around a lot of options and we're very open to saying, well, yeah, sure, you could do that and so on. And I think we're not hard enough on ourselves to say where we've really got evidence that we've got some habits we need to get over. So the first thing that I think is, to me, very obvious from Andrea's data is that mismatch repair status is the first thing we need to know before we know what disease we're treating in colon and rectal cancer. And until we know that, we really don't have a treatment plan. So consistent with what we did last year with NCCN guidelines, where we underwent what I call the Great Schism, where we separated the guidelines into mismatch repair proficient and deficient right from the start. That's the way we need to be thinking about approaching our patients. I also think it's time to let go of our old approach. The idea of chemoradiation upfront, followed by surgery or an operation, and followed by chemotherapy was the old standard. It's out of date. It's not really something that I can think of any circumstance where that's the right answer now. So total neoadjuvant therapy should be considered our current standard in those patients where radiation is going to be considered. So the next thing that I want to bring up in terms of things that I see done frequently, and I'm still scratching my head as to why, is please don't get a PET scan. If you look on every page of NCCN guidelines that talks about imaging, you will see the words PET is not recommended. And the reason for that is it's not as good a test for colorectal cancer as a good contrast enhanced CT or a quality MRI. Those are the preferred imaging methods. The fantasy that PET somehow magically sees things we don't see on the other imaging modalities just isn't borne out by the data. And in fact, we get a lot of false positives, which I've come to call PET poop. And these lead us down the wrong pathway and can often interfere with care. So it's not useful for pretreatment staging. It's not useful for RT planning. Most of our radiation therapists don't use it. If our people don't need it, I don't know why somebody else would say they do. It's certainly not to assess for a clinical complete response. Those data have been answered a long time ago. There are both false positives and false negatives in that area. And it's not indicated for post-treatment surveillance. Now, the next thing not to do is if you're doing total neoadjuvant therapy, there isn't a role for re-imaging between the radiation and the chemotherapy, especially if you're doing radiation first. There's really no finding that would lead you to determine anything different about what you're planning to do with your chemotherapy. So that imaging was not part of our standard practice, was not part of the Oprah trial, is not part of NCCN guidelines, and really shouldn't be done. Now, the caveat, if you decide, and I agree very much with Andrea's statement that we don't have the final word on the order whether chemo followed by radiation or radiation followed by chemo is the preferred way to go. However, giving chemotherapy first does give us the opportunity to evaluate before radiation and see if we're in that lucky 22% that have had a complete clinical response. So if you are willing to discuss with your patient the option of expectant observation and watch and wait. I personally prefer the term active surveillance. Watch and wait kind of implies negatively we're waiting for trouble. If you're going to stop after chemo with a complete response, then a scan is, of course, indicated. If that's not in the cards, if you're not willing to go there, your patient's not willing to go there, the scan really doesn't change anything. If you're doing TNT, notice that the first T stands for the word total. You're giving all of your treatment up front. don't consider adjuvant treatment. And no, I don't agree with the Protease 23 treatment schedule. I think it is a massive overtreatment regardless of what we do up front. We have reams of data, reams of evidence from the IDEA study that we get virtually all the bang for the buck that we're going to get with 3 months of oxaliplatin. And so I don't give more than 3 months of oxaliplatin to any fellow human being in the curative intent setting anymore. The data just do not support it. And it's important to remember nothing works either for the treatment or the prevention of oxaliplatin neuropathy other than not giving too much oxaliplatin. None of the therapies we've tried for prevention, none of the therapies we've tried for treatment are effective. So we really have to be very careful about how much of this very toxic drug we give to patients. And finally, yes, Shahina, I will close by saying, please don't use circulating tumor DNA. It has absolutely no role in the management of patients with colorectal cancer. It is not useful for pretreatment baseline. It is not useful for post-treatment of following. It is absolutely not necessary or useful in any way for non-operative management, and it's not useful to follow post-operatively. And the reason for this is it doesn't give us actionable information. It can give us a warm, fuzzy feeling if it's negative and make us falsely comfortable. It can give a cold chill down our spine, probably truly so, and make us very nervous if it's positive. That can traumatize patients, but we don't have any evidence that initiating any sort of therapy simply on the basis of a positive ctDNA is the right thing to do. And so there we get into over treatment, which is not in our patient's best interest. As Andrea mentioned, there are clinical trials. We're participating in one, but there are several that are asking the question of whether or not this is beneficial to patients. I'm always supportive of a legitimate clinical trial with a legitimate question, but outside of a clinical trial, don't use ctDNA. And I emphasize this is not currently ctDNA in any form for surveillance is not recommended in ASCO guidelines, NCCN guidelines, ESMO guidelines, or Cancer Care Ontario guidelines. And so my final slide, really, please don't do it. Thank you.
That was great, Len. Thank you so much. I think I agree with all the statements, but as you would see at Sloan as well, most patients come with the PET scans. And Suprita has a very good point. ESMO says PET is to be done. And in the NHS, actually, the only indication for us, because when the PET scan started, the only indication that was funded, Gina, if you remember, was a rising CEA. That if you
yes, and that's and that in fact was the first funding by Medicare, Medicaid in this country in the early 1990s, and it actually makes absolutely no sense. Firstly, that got started because what was happening is people would have a rising CEA with a poor quality community CT scan, come to the limited number of academic centers that have a PET, would get a PET, the cancer would light up, they'd get a good quality CT scan the next day, and the cancer would be clear as a bell. So that it was always a false narrative. But even if you accept that, consider the possibility. I've got a patient in surveillance, the CEA bumps. I get a good quality contrast-enhanced CT scan, and I don't see anything. What would I normally do? I would get another good quality scan in 3 months. What happens if I get a PET? One of three things. The PET shows me nothing. I'm going to get my quality CT scan in 3 months. The PET shows me asymptomatic small volume disease in a non-surgically manageable pattern. There's nothing for me to do. I would be over-treating if I treated that asymptomatic patient with chemo any sooner. What am I going to do? I'm going to follow the patient. I'm going to get my quality CT scan in 3 months. Last issue, we get a focus of potentially surgically removable disease. A single area lights up in the lung or the liver with no morphologic imaging correlate. No responsible surgeon is going to go in on that. What are they going to do? They're going to get a good quality contrast-enhanced CT in 3 months. So if every option possible leads to a follow-up in 3 months with a CT, why do you want to spend money on a PET?
Yeah. Shahina, you have a question?
I had to ask a question, right? So no, I agree. I actually don't do ctDNAs or MRD testing in patients with rectal cancer. But I'm going to just go off topic here for a while. I know we're only talking about rectal cancer, but what about helping to select those patients with stage 2 colon cancer? Would you consider doing MRD testing there with the data that we have at present? I'm still skeptical, I have to admit, but I'm seeing my colleagues actually request it. And so that's my first question, Leonard. And my second question, so you can answer both together, is I don't request any PET CTs for rectal cancer, but I find that my radiation oncologists want it. And they say it helps them in their treatment planning. I'm not sure how, I'm not a radiation oncologist, but they want it for that purpose.
Yeah, I'll get to the second one first. I'm not a radiation oncologist. I can just say that our people aren't asking for it. Okay. And we've got really good radiation oncologists. So,
no, we never do it. I'm a radiation oncologist, and we never ever require.
Yeah.
PET.
Look,
Okay.
if Chris
All right.
Crane
I
and
just
Paul
find a lot
Ramos
of the radiation
don't need it.
oncologists are
Yeah.
requesting it.
I understand. And look, there are some who disagree with me. Karen Goodman, who used to be at our shop, loves PET scans. And I think the world of her, but that was one issue that we really disagree on. So look, not everybody's going to agree on everything. What can I say? Okay, I'm sorry. Your first question was
MRD testing in stage 2 colon cancer.
Right. So, again, I think it's been wonderfully well marketed at people, and it really is a wonderful way of massively driving up the cost of healthcare. By the way, it's very expensive. It's usually about $7,500 for the first test and $3,500 for each subsequent one. People want to pretend that it's, quote, free. But if you look at the New England Journal article that Jeannie Tai had, which I was really kind of surprised made it into the New England Journal, actually what they showed is that by decreasing the number of people that got fluoropyrimidine only, but substantially increasing the number of people that got oxaliplatin, because the people with the ctDNA driven got 10% of those patients got oxaliplatin versus 2% in the control group, that they got the exact same outcome. And the outcome was 92% 3-year recurrence-free survival, which is kind of what we would expect for a stage 1 population. So I don't understand that article at all. It doesn't tell me anything. They had a remarkably good group of patients that were going to do well no matter what. And in fact, their control group had numerous patients with high risk factors who were not treated. It was a random, physician's choice, not a defined control group. So that to me is a completely non-starter as a reason to do it. The bottom line is that the negative predictive value is really inadequate. And so where I want it to be good enough, where I want to get ctDNA that I can use to make a decision, is when I'm confident enough that in a person I wouldn't treat anyway, that I was going to treat, that a negative ctDNA says not to. Telling me that a T3N0 without any risk factors is ctDNA negative doesn't tell me anything, because I kind of knew that anyway. And if that person is ctDNA positive, I don't know what that positive predictive value is, because all the data that's out there is self-fulfilling. The bad cases that we already know are bad cases have a high incidence of ctDNA. And we've got very little data on the incidence of ctDNA in stage 1 and stage 2A colon cancer without risk factors. So until I see those kinds of data, I think we have to not give into the very aggressive marketing. This is a multi-billion-dollar industry that's popped up overnight, and patients are being taught on the internet to ask for it. And I think we have to explain to them why it's not in their best interest.
I agree. My last question actually pertains to both Gina and yourself, because she's the radiologist. But again, coming back to that PET CTs question. So I've seen patients come to me with MRIs being done and PET CTs, and they're already done, and we're just reviewing it at our center. And sometimes what we find is that an MRI is the gold standard. The CT chest, abdomen, pelvis is done. They've also got a PET CT scan, and the PET CT scan is picking up some more distant lymph nodes. What do you do with that when it's just active there and it's not being picked up on a CT or an MRI? I think it just makes life more complicated. But what are your thoughts when that actually happens? Because we face it a lot over here.
I'll let Gina answer first, but I have my thoughts.
I think Len and I ought to write a little piece on this, because I'm sure we've both seen the same thing, which is these so-called positive nodes And I think
Yes.
Len's paper should be called Pet Poop. The story of what not to follow.
All
I
right,
think
that's
a
done. Bhavna, please make sure that this happens.
yeah, because I think the thing is that we've seen it a lot, and it's one of those things that radiologists love this phrase: no size significant enlarged nodes demonstrated.
Yeah.
And what does that even mean? Essentially, patients produce lymph nodes. Those lymph nodes can be hot on PET, and then 3 months later, those lymph nodes are not hot on PET and they're not enlarged. What does that tell you? It tells you that the patient's produced a lymph node that's reacted, enlarged, and we all produce them. When we get a cold, we produce a lymph node in our necks. And what does that mean? It doesn't mean malignancy. So I do think that you have to take the context of the biology of the disease. And as I say, I think that the presence of EMVI in tumor deposits means that you've got a sinister pathway of spread. You are going to have MRD. You are going to have spread that needs quite careful surveillance, the most optimized treatment. A lymph node positive or negative doesn't change that fact, and therefore shouldn't alter what you do for that patient. So I honestly don't. I agree with Len. I think PET has been well over marketed and overrated. I think it can be useful if you really are embarking on a major sort of exempt, and you just want to make sure you're not embarking on that for some, ridiculous thing that turns out to be something that a radiologist missed. And that's usually what it is. It's what Len was saying. It's radiology misses. We are human. PET can save us from those. Most of the time it doesn't matter, but in a situation where you're about to embark on something, really intense, perhaps it can be useful in that scenario, but not as a routine.
Great.
So Gina said it more eloquently than I will, but basically my answer is I don't pay any attention to it.
Okay.
And that because it's a distraction from our best available information. And if I thought it was useful, I would get it on everybody. I don't mind spending money to take care of patients. I hate wasting it. And I think that the concept of more is better is a misunderstanding that comes from this scenario we're in, where everybody is spending somebody else's money and not stopping to think about what is the up and downside of the intervention. Same with ctDNA. Somebody brings it to me. I say, that's nice. If I knew how to use it, I would have gotten it before you got here. But since I don't know how to use it, we're not going to act on it.
That's great. Dr. Ashwin D'Souza, you are here. So maybe I'm going to whiz through some of the questions that we were going to discuss actually. So in your clinic, at Tata Hospital, do you do PET scans or because patients come to you first in the GIDMD?
No, we don't do PET scans at all as a routine because first of all, we have nearly 18 to 20% of signatoring also, and they don't have the glute transporter, so we miss those out as well. And we also have a very high level of granulomatous disease in the chest. So they almost always pick up these lymph nodes in the chest and we end up chasing them. So no PET scans at all at baseline investigation, none at all.
Sir, you brought up a very important point that we didn't touch on, which is not only does PET have a significant false positive rate, but as you mentioned, a very significant false negative rate, especially in the mucinous tumors.
Yes, absolutely. And we see more of signet rings in India. So I'm going to finish on time, actually. We only have 5 to 7 minutes because I understand 1.5 hours is long. I'm just going to discuss one of the key points which Dr. Mau Roy, our surgeon, has brought up actually on the chat. This is one of our patients. Just to tell everyone also, we published our local guidelines with the help of Gina and Aparna from NCCN and ESMO. We thought, let's get the international inputs as well. So thank you, Gina, you are here. So this young 25-year-old, I think the key question here is, Aparna, you are here on the call. And Andrea showed the MSI high, very well represented. This young lady actually... So the question here is treatment effect after long course chemoradiation, FOLFIRINOX, which she struggled with after long course chemoradiation, was literally absent. It was T3N2A disease, R0 resection. She was circumferential resection margin positive, EMVI positive. When we started, if you look at, it was from 3 to 9 o'clock, 3DN+. So what do you do here? I would love to hear what, I mean, this lady has a lot of residual disease. The question is, would you give, she had 4 cycles of FOLFIRINOX. Would you give like maybe 2 cycles of CAPOX here? I'd love to know, Len, Viraj, whoever, Shahina.
So my argument is you give everything you want to give up front and then you're done. And I never agreed with the studies, including our own, the Prospect study. It was simply the way we had to do it at the time, that split chemotherapy. Usually that's a matter of a decision by committee where it's getting late. Everybody wants to go to dinner. We can't agree. So we split it and do half before and half after. If you think about the logic, okay, you've already given fluoropyrimidine oxaliplatin containing therapy for as long as you did. And in that time, with each cycle, you have killed some of the cancer cells. By definitions, they're the sensitive ones. And you've not killed some of other cancer cells. By definition, they were more resistant. With each subsequent treatment, you're having a bit of a Darwinian selection for the more resistant ones. Now you stop, you wait a month, you operate, you wait a month to recover, and now you're going to hypothesize that more of that same chemotherapy is going to eradicate that same tumor that's now been selected to be more resistant and been given a couple of months to repopulate. It just doesn't make biologic sense.
Yeah, that's true.
So it's another example of letting our anxiety cause us to not do the responsible thing and control our anxiety and instead subject the patient to toxic therapy.
Yeah. So would you just observe this patient?
What else could we do right now? We don't know. We don't have a better option.
Yeah.
This is somebody that, of course, is high risk. And now people are saying, well, do we have to observe them more closely? Should we get a scan every 20 minutes? Should we get ctDNA? And the answer is no, because if they're asymptomatic, that's a blessing. Enjoy it. Don't traumatize them with all this information, because each time we do an assessment, the emotional drain on the patient is enormous until hopefully it comes back negative. But the fact is that if they're asymptomatic, we're in no rush to find out what is happening. We can give the person some time to live their life. And if we have a problem that's symptomatic, we'll work it up. And otherwise, our regular surveillance is appropriate to find what we're looking for, which is surgically resectable recurrence. Remember, we're not looking for an early reason to start chemo because our chemo's not that good. So we have to have a bit of humility about what we can and can't accomplish and wait for the pattern to determine, is this true oligometastatic disease where surgery is going to be helpful? If we find that first little sub-centimeter nubbin and send the surgeon charging in, all too often, by the time the person's recovered from the operation, the next area is showing up. So we really have to wait to find out, is this a not that metastasis competent disease that can spread everywhere? Because if it can, it will. Or is it not all that good at being a metastasizer, in which case it will only have a few, oligo is the Greek word for few, areas of metastasis, and that's where our regional or surgical approaches can be helpful.
So I would agree with Len. My question is, so this is fascinating and very scary biology. And it's concerning and also interesting that you're seeing a lot of these patients because we certainly don't. So was there on the pathology, I guess they received radiation. Was there any treatment effect? Did they comment on that?
Yeah, I mean, it was no evidence.
No response. Okay, so it didn't really touch it. That's actually really, it's scary. So it's a young patient. I agree with Len. The only thing you could say, and I think I would convince myself this, but Len is right, is that it was only 2 months of 5-FU and oxaliplatin, and technically, if it's FOLFOX, it really should be in the adjuvant setting. If we're thinking about micrometastatic disease, 6 months of therapy. So I personally, but more driven by sort of fear than anything, because obviously the response was terrible here, would give some more chemotherapy just to sort of say, okay, I really gave it my best shot, because I'm just truthfully really scared for this patient.
Yes, I mean,
Well, the one thing we're all in agreement on is we're scared. Okay,
Yeah.
we don't understand it. It's not what I almost wonder, Andrea, should we be thinking about looking in some other way to verify that this is in fact mismatch repair proficient.
Yeah, I just messaged Rena actually to definitely do NGS, because I'm wondering if it is, maybe it's POLE, maybe that's what it is. They don't typically not respond to chemotherapy, but maybe that's the issue.
I was thinking more, Sophia Stadler, who is our expert on all things genetic
like
when it comes to GI malignancy, is always saying 5 to even up to 10% of people, there is a protein that shows on immunohistochemistry that is dysfunctional.
Yeah.
And as a result, you do in fact have a mismatch repair deficient tumor with a false positive immunohistochemical stain. So NGS would be a really good way to confirm. We found that that's the single best way to confirm. And what you're really looking for is the mutational burden. If you've got a sky-high mutational burden, you've got mismatch repair deficiency. If you've got an off the charts, you've got POLE mutant. And if you've got relatively low in the 0 to 15 range, you've got mismatch repair proficient.
Yeah, I agree, because the histochemistry really smells sort of MSI, just the description. So I think for whatever reason, maybe it's the assay. Maybe it's the assay that's not picking up, the enzymes. Sometimes if the enzymes are not working well, maybe that's the issue. But if you can get NGS, I think that will be super informative here.
We'll do that. And maybe Reena, Ashwin, we can combine. We have a lot of patients like this here in BMC. Maybe we can combine our patients and do the
20% of all our patients are like this only.
Yeah. So maybe we can combine these and do the NGS, get it funded through somebody.
That would be an interesting analysis. Although I would caution you that unless we're lucky enough to find out that there's some interesting, mutation that's not showing up on the IHC, we've been looking, I would say now for about 20 years, to try to understand two things about 5-FU oxaliplatin. One, who responds and who doesn't. We really don't have a clue. And the other is, why are the primaries so more sensitive than the metastases? And again, looking at matched settings of mutations, we don't see a difference. So it would be interesting to dig on this, but I'm not optimistic that we have the technology now to understand a resistant patient from a sensitive one.
Yeah. Great. I think I'm going to just, Aparna, any comments? You haven't spoken at all. So my next patient was actually MSI high, MSH6. Basically, she had a sigmoid and a rectal primary, dual primary. This is a young lady. And both MSH6 expression was lost. So Aparna, are we seeing more of, we were discussing with Harsh in our molecular MDT, we're seeing more of MLH1 loss in Indian patients. Is there something which is different from West?
I don't think it's different from the West. I do think it's pretty similar. MLH1 is the most common common gene that we are seeing in our familial colorectal cancer cases. I think it's worldwide. It's not just here. We thought it would be different in India, but we do have certain founder mutations depending on where the individual comes from in India. That's where we are slightly different from the West, but MLH1 still tops our list. And actually, to go back in our Indian laboratories, MMR, we've had a lot of times where it's come proficient, and on NGS, we are picking up around 7 to 12%. I do know in my previous organization, it was around 7 to 12% where we saw discordance. MMR was stable. When we did NGS, it was MSI high. And we, in fact, in some cases, we even found link genes. So I would not take MMR as, if you have any of the red flags, young age of onset, family history, pathology, adenocarcinoma, signet cell carcinoma. Signet cells can either be Lynch or sometimes it can even be associated with CDH1, which is gastric diffuse cancer, hereditary gastric diffuse cancers. We also see colorectal cancers in that cancer subtype. So if you've got all of this, and irrespective what MMR says, I would still go and do germline or somatic, especially there are therapeutic implications with MMR. Otherwise, it was really interesting listening to everyone, so I was very happy being quiet.
Andrea, last question. I mean, so this patient we gave pembrolizumab to and she's doing well right now. She's had an excellent partial response on sigmoidoscopy in the sigmoid tumor and the rectal. Are they interchangeable, and do the MSI high, they all behave the same?
So I would say, yes, they are interchangeable, the PD-1s. There's no reason to think that they're any different. So we used dostarlimab on trial, but we do have now, per NCCN guidelines, the ability to use pembrolizumab or nivolumab or dostarlimab. And I think there is a difference in response. We have expanded the study actually to all solid tumors that are mismatch repair deficient. So the responses are still incredibly high, much higher in early stage disease than in advanced disease, but there does seem to be a bit of a difference anatomically. And we're looking into that, whether it's probably the microenvironment for whatever reason being more permissive to immunotherapy in the rectum than as we go kind of higher up to the esophagus. But we'll hopefully figure out why that is and what the differences might be and what's driving it, whether it's the tumor genomics or the microenvironment.
Great, thank you. This is my last slide. Ashwin, do you agree with this? And I think, Len, you emailed as well whether MSS high rectum, whether we could go for a prospect type approach. And for distal rectum, we try and do TNT and try and get them to a non-operative management.
Well,
Yeah,
I would
go ahead.
emphasize.
Go ahead.
I'm sorry. I just want to emphasize prospect was high and mid rectum. High rectum was already almost an established standard before prospect was done. And high to mid rectum is where I think we have an option. We can even be thinking about it in low rectal tumors in people where their priority is to avoid radiation. So talking with the patient, finding out what his or her priorities are vis-a-vis the long-term side effects is critically important.
Yeah, thank you. Ashwin?
Yeah, for the high and mid rectum tumors, we do see locally advanced tumors here that actually go into the presacral fascia, stuck to the anterior cortex of S1. So they are not all the early ones that sort of were included in prospect. So I'm not going to rule out radiation for the upper and mid rectal totally. I would be really uncomfortable to avoid radiation in these locally advanced upper and mid rectal tumors as well. That is one. And because we see these large group of these patients which have this unfavorable biology, very little response, when giving TNT, we tend to reassess a little earlier. We won't wait for 6 cycles of chemo, because if the patient does have, can be resected R0 with an extended resection, there is that risk of progression if we wait too long and the chemo is not working. So we would probably reassess maybe after 3 cycles before, not wait till about 6, because then we lose that interval for a curative R0 surgical resection for these patients.
Great, thank you. Any last thoughts from anyone? Dr. Mao, Gaurav, anyone? Great. Thank you, everyone. I'm really grateful that you've given your time for this, and hopefully we will meet again. Thank you so much, especially to the international and national faculty.
Yeah. Ma'am, I have one question.
Go ahead, Dr. Mao. Yeah.
For the unfavorable distal rectal tumors, should we incorporate diagnostic laparoscopy in staging protocols? I have a question for Dr. Ashwin, because we are seeing peritoneal failures in young patients. So should we incorporate staging diagnostic laparoscopy first before starting treatment?
In fact, Ashwin, the paper we wrote in rectal cancer, most of the signet ring patients had peritoneal recurrence.
I think it was 20%, if I'm not mistaken.
Yeah.
But most of those patients required either a diversion because of the extent of their local disease. So they would sort of get a staging laparoscopy and a stoma in any case, most of those patients. But as a standard guideline, I don't think we can recommend a staging laparoscopy as blanket for all these patients. No.
Okay. And other question is role of HIPEC in rectal cancers.
Oh, that's very simple. Absolutely none.
None.
Yeah,
Agreed.
I think that should be
On
one of
that-
the other slides.
On that note, I apologize, but
Me too,
Thank you so much.
excellent.
we gotta go.
Thank
Bye-bye.
you.
Bye. Thank you,
Take care.
River Root and Cipla as well. Thank you. Thank you.
Bye-bye. Thanks. Very excellent discussion.